And now I call Deniz Bulija to tell us something about pressure cooker technique for the treatment of the cerebral AVMs and what can go wrong.
Pressure can be hard, yes. Okay, so this is my session. So I was supposed actually to give a lecture about complications on cerebral aneurysm treatment. However, I had yesterday something similar, so I decided not to repeat some of the cases. So this patient qualifies for both MOMO. So unfortunately, so nothing to disclose, and for the sake of time, I will skip some of the text, and we all know about curative potential of embolization, endovascular treatment of AVMs. It can be adjunctive to surgery or as a standalone treatment as radiosurgery for some AVMs, and of course during transarterial deployment of embolizate, we need to look closely on not to have premature venous occlusion, which can be devastating, result in devastating consequences. And of course, sometimes you have AVMs with en passant or tiny arterial feeders, and in this case, it's transvenous approach can be performed, and of course, despite its challenges in achieving of adequate needle penetration without early compromise of venous drainage, this can be taken into consideration if you know what you're doing, of course. There are some relative indications for this. One is you need to have relatively small AVM, less than 3 centimeters, at least according to the literature on this. It has to be deep-seated with a high operative risk, and usually you have ruptured AVMs in this case, of course. You need to allow some time to pass before treatment. And as I already mentioned, en passant arterial feeders, tiny arterial feeders are those the type of AVM which can be treated with this technique. So the first report that I found online was actually from Val d'Isère conference in 2003, followed by another reports from 2005, and it is hazardous. And if you look into online literature, and there are some guys here who performed this, of course, you can find only small case reports, and again, you can find two major studies published by Monayer. Most probably, first one was included 38 patients, and then I think he just added another 35 patients to this 73 patients group, where he introduced this concept of porcelain vein, which actually relates to circumferential centripetal deposition of copolymer, vinyl alcohol copolymer, along the vessel wall during reflux, which progressively reduces the diameter of the main venous drainage. So you need a plug on the venous side, you need a plug on the arterial side in order to control the reflux and to actually fill the nidus entirely or angiographically entirely. And this fact complicates the procedure with the need for multiple microcatheters instead of one. So this was the patient that we treated. It was male, 55 years of old, with a massive hemorrhage in April 23. So it was a really slow recovery, so he was in hospital forever. So in early June, the neurosurgeons actually decided for us to treat the patient. Really tiny arterial feeders, deep-seated AVM, less than 3 centimeters. I don't know about the location. Maybe the location was actually good for neurosurgeons, and I think so. It's quite simple, you know, but they insisted on our treatment, so it was something that we actually reluctantly did. And this was set up, so transarterial transvenous phase with the systemic hypotension of the patient. So this was the AVM. It was really pretty easy actually to get from the venous side and from the arterial side. And from the venous side, so here you can see maybe from the venous side we only implanted one coil. I think that was actually the major problem maybe. From the arterial side it was a balloon and of course the additional microcatheter Apollo 5 centimeter detachable tip was responsible for filling of the AVM, and in this case we had on shelf only fill 25, so we used it, and of course it doesn't create a good plug, and you can see the filling of the AVM. Yeah, there was some force required for the detachment of Apollo microcatheter. Maybe, of course, it tangled. Some of the cast actually solidified against the microcatheter. And at the end, it was a good, actually, result. So I spoke with the patient on the angiographic table after the procedure. The patient actually felt well for that day, and next day he died in half an hour. So I don't know what happened, you know, because they didn't perform even CT for this patient. So I'm not sure whether it's hemorrhage or not, but when I look back, you know, I should have coiled maybe collector vein more heavily and include some NBCA glue there, and maybe I was reluctant in going into the procedure with this patient, and I was actually forced by the neurosurgeon, so maybe I should stand more firm in this situation. So for you who were not in the room yesterday, just to repeat that our National Interventional Radiology Society is organizing Congress this year. It will happen from 6 to 8 November in Sarajevo, so you're cordially invited, and you have a web page here for more information. Thank you.
Thank you, Deniz. So the question for the audience: do we see this later potential rupture after 12 hours, 24 hours?
Usually, patient deteriorates pretty fast, you know.
You mean after procedure or during the procedure?
Yeah.
What is the reason to choose the transvenous here? And when I looked at the images you show, that is a clear aneurysm which causes rupture in around the nidus.
Yes.
Orienting inferiorly mostly.
Multiple of feeders and some small feeders directly from the MCA. You know, and that was the only reason to go transvenous in this case.
Is there any feeders can be catheterized, or just you think that transvenous is much easier? I mean,
for me it looked that it would be much easier to go from transvenous side.
At the end, you know, I'm using time this technique, that transvenous, but still I have a lot of problems in my mind to do so.
Me too.
especially the AVM with a nidal aneurysm, already ruptured, weak points. If you change the hemodynamic by occluding the veins and cannot reach that aneurysm, yeah, you can use that camionette picture.
Yeah.
You are in a shit. But for sure, in the deep AVMs, time to time it is impossible to use transarterial. And the only way, only option is the transvenous. I'm not against to do transvenous in those locations. But for this, for example, if I, of course, this, I'm not criticizing the physicians of decisions, but if I have this case, for example, that is easily doing by an open surgical technique. I mean, that hematoma create a cleavage, and you already weigh too much after hemorrhage, and then it's reachable by open surgery, and I don't know, it's a kind of the gambling to give those cases to the endovascular therapist.
This actually left bitter taste in my mouth because it was gambling, you know, as you said. I'm not neurosurgeon, you know, but from my experience with neurosurgeons, I think this is easily resectable by neurosurgeon. And it's the best
you did
therapeutic
good. I
option
mean,
for
the
patient.
positioning of the balloon and also positioning of the catheter. Your injection is infiltrating quite nice. You know, you technically you did good actually.
But it was not the right choice. Yeah.
Thank you for showing.
Thank you.
Going to
Now
the
we're-
next case.
Okay. Can I introduce you?
Yeah?
So we're continuing with the next presentation. It will be presented by Ivan Vukasinovic, and the topic is complications in our endovascular field.
Yes. I have a lot of complications, but this one I chose is for thrombectomy one. So 72 years old woman, wake up stroke, NHS score was 18, the usual things, aspect very good, 9. And the hypertensive sign of the left MCA, so usual thing, you see and this was the CT angio. So on the right, especially on the left, you see this diving MCA, but nothing, again, nothing unusual what we don't encounter. And this was the perfusion. So very small core and big penumbra. Penumbra was almost 100 milliliter, and the core around 10 milliliter. So this was the procedure. First of all, we started with the most soft catheter we have, which is Sophia, and then we started to try the aspiration. But there was a lot of difficulty to pass this point of the curve going down, even with the 5 French aspiration, which usually goes anywhere you want. So again, after this aspiration, because the catheter was not near to the thrombus, we did nothing achieving. And but you see, it's a big artery, and we thought if we could get closer, we could surely do something to help the patient. But then again, another pass with a stent retriever, with the aspiration. Again, stent retriever passed very easily, but the aspiration catheter couldn't. We retracted stent retriever, and this was the result, nothing. And now it becomes personal. So we want to do it. We want to recanalize the artery. It seems reachable. It seems something that we already done. So we do another pass again with this aspiration catheter, and this is the situation. So there is a rupture, and the big one. You know, surely for this kind of coiling, but like temporarily coiling, to start to close the gap, the bleeding part, and to try to save the other branches, but it didn't work. Only one coil couldn't stop the bleeding, and eventually we needed to close the artery with coils, complete closure of the M1 segment. And this is the result. And of course, it was not good for the patient. You see the immediate CT on the in the cath lab, big bleeding, big hematomas in couple of times. So this is the 48 hours control, and fortunately or unfortunately for the patient, he was discharged with a MRS5, meaning he was still alive but severely disabled and hemiplegic, and left to care to his family. And what went wrong? We looked to the images. This is the bleeding. This was the before bleeding, and what we of course find out after the battle, we found that there was some bleb or aneurysm with a large neck, you can call it like that, on the M1, M2 curvature. And if you look closely at the CTA now, when we know there was a rupture, you should probably appreciate there was a small aneurysm, and of course the reason why the catheter couldn't bend and go down to the site of occlusion. Yep, you see it here very well. So the point is, we should always look for these kind of problems. Sometimes the clot is proximal to the potential aneurysm, then we look for the mirror aneurysm on the other side. But we shouldn't rush into the intervention and look carefully for the imaging that we have before it. Thank you.
How much passes do you do with the stent retriever before bleeding?
This was the third one. Third one. Yeah. Yeah.
Thank you very much for sharing those cases which happened all to us. Did you consider a balloon also to close off temporarily the M1, M2 segment, or?
Yes. That's another problem. Don't think we do the thrombectomies in another cath lab. So the balloons that we have for the aneurysms were there. But anyways, we have the balloon, we have coronary balloons, we have balloons. But the first idea was to close it with coil. But I agree with you. But my personal feeling that it won't close with the temporarily balloon because it's too big hole.
Yeah, probably.
But you're right.
Ivan, you said the stent retriever passed through that occluded segment without any problem.
The microcatheter and then
Yeah, the aspiration catheter is not.
No.
In general, actually, always, if I'm using stent retriever, I'm opening it up, cross the bifurcation, and having a run. This is for sure that you show the aneurysm, but that run give you a chance why you are not passing through. Because whatever you do right now, okay, if we accept that the rupture coming from aneurysm, you didn't take the clot out.
No.
Yeah, but the clot was there. when the rupture there.
Mhm.
And then mechanically that aneurysm is ruptured. That if you have a run showing you that the vessel is opening well with the stent retrieval, but you're not passing through, maybe you may stop to push your aspiration catheter towards the bifurcation. Even time to time, you may use stents permanently, not retrieve the stents in certain cases. Just an idea, because you didn't show us the run with the halfly deployed stent retrieval. Maybe you
Yeah.
did. I don't know. What do you think?
Of course, usually what we have when we cannot pass with aspiration cutter, then we anchor with stent river, and then 99% we pass. So this was the attempt, and then did this attempt second time, he made the rupture. But you're right. But we never do that, this run when we open the stent river. This was the old technique, and then we. In time passing, we left it, we don't do it anymore, just to see how it flows. But of course, if we knew that, then either we won't do anything, or we could easily pull the stent retriever and went out. But this could only also damage the aneurysm.
Because this occlusion is away from the bifurcation, so-called bifurcation, that upper one is tiny, not at the bifurcation.
It's a dominant M2.
It's a dominant
yeah.
M2, and should be there. Most probably the dissection, or that the heart thrombosis is already there. So that the push the aspiration catheter towards that possible dissected segment, which may be done by the operator, I think that is the tricky point of this case. Eventually, yeah, it is catastrophic rupture over there, but you managed to occlude it. But it is happening time to time
Yeah,
for us.
yeah.
Thank you for showing.
Thank you.
Thank you.
Thank you. Bye.